Thank you everybody for coming along today to our latest DARIA session. Today we have Dr. Jonathan Brett, who's a clinical pharmacologist, toxicologist, and addiction specialist who works at both St Vincent's Hospital and at the New South Wales Poison Information Centre. His main, at the moment at St Vincent's, he's heavily involved in the PANDA unit, which has been a great initiative by St Vincent's Hospital and is going very well. Dr. Brett has a number of grants and projects that he's working on, but he's modestly said I can refrain from listing them all right now. That he is very well credentialed in the world of addiction research, and I'm sure will provide an excellent presentation today around psychedelics for methamphetamine use disorder. So over to you, Dr. Brett.
Thanks very much, Chris, and thanks for inviting me to talk on one of my favorite subjects. So just start by acknowledging traditionals of the land we're meeting. I'm actually talking to you from Gadigal land, but I imagine you're all in different places there. Just to acknowledge that the land was never ceded, and to pay respects to elders past and present. So psychedelic psychotherapy is quite a buzz at the moment, very topical. And as with a lot of these new things, I think it's still in the very early stages. And I think just a sort of note of caution in that, my sense is from the early literature, it definitely shows promise. But it's certainly not a panacea. And, I think a lot of people are looking for a magic bullet or a quick fix. And in my perspective, it certainly isn't that. And so just to use this metaphor of kind of climbing a mountain, it's darn hard work. And actually, not everyone reaches the top, but it's certainly very helpful if you have some people to kind of help you, guide you up, and once you get to the top, it's you've got some good views there, I guess. So psychedelic psychotherapy very much is about, in my perspective, facilitating psychotherapy and not primarily a pharmacological intervention. So I see it as taking the psychotherapy modalities we already have and I think do relatively well in drug and alcohol, and being able to enhance them. And I'll talk through some of the theories about how that might be possible, but certainly, it might be able to help people move along in their beliefs or thinking about things. The key step is to translate that into behaviors and changes in sort of life environment. And that might be some of the reason why, while you have an initial good response in some studies, there is a fairly high rate of relapse. And it's probably because of that sort of next step element in being able to translate to changes in your life. But we'll come on to talk about that. So what are psychedelics? And apologies for those who've seen this before, but psych means mind and deling means manifesting. So psychedelics went through a number of sort of iterations in names before they reached this stage. They were known as psycholytic at one point and a number of other things. But they've been around for an incredibly long time. So we know this because there's a number of sort of historical artifacts showing, shamans and various other kind of people and rituals historically engaging in this kind of thing. So this is apparently a shaman engaging in with some mushrooms here in Algeria, and then other historical artifacts, a lot of which are from Central America. There's these really neat little kind of stone mushroom gods that were kind of used as part of rituals in Central America, dating back to 3700 BC. But more recently, this is what's happened. So I've separated this into like the rise and fall and then the re-emergence. So you might be aware that Albert Hofmann synthesized LSD in the early 50s there, and it was kind of an accident. He was looking for drugs that might act as circulatory and respiratory stimulants, and then he kind of describes this experience of allegedly accidentally taking LSD and having this really wild psychedelic experience. Interestingly, he was also the one that first synthesized psilocybin and psilocin, which are the compounds in psilocybin containing mushrooms, psilocybes. So he's kind of, in some circles, like worshipped as a bit of a god in the psychedelic space because of these achievements. So in 1947, the first pharmaceutical company Sandoz actually started marketing LSD, and that was in the times when you didn't actually need much evidence to apply this in clinical practice, and so it was kind of available for therapists to use in a fairly unregulated way, and that led to a number of other issues and consequences, which you'll see. But there was a kind of bit of a darker side to psychedelics as well, as you may be aware. So actually, this guy here in the 1950s is Ted Kaczynski, otherwise known as the Unibomber. So he was a psychology student at Harvard, and around the time the CIA were performing experiments in interrogation using LSD, and actually he and sort of other people attribute his kind of sociopathic beliefs, I guess, to this kind of this time experiment, the MK Ultra experiment. So a number of other things happened around the 50s. Aldous Huxley published this book called The Doors of Perception from his experiences using mescaline, and that kind of popularized the psychedelic experience. And then again in 1955, Gordon Wasson published his experiences using psilocybin with this kundera in Central America called Mare Sabina. And those things really popularized sort of psychedelic experience. So then along comes a group of people called Timothy Leary, Ralph Mertziner, and Richard Alpert, later known as Ramdas, who actually just died. And they started this Harvard psilocybin project. Interestingly, they were all fired not long after starting this up because of integrity issues around trials and around sort of promoting recreational use of psychedelics. And so that was kind of the start of some, I guess, zealousness around the use of psychedelics in health, which later led to its discredit. And then, around that time as well, LSD started to be used recreationally. So the fall, again, there was a number of people kind of promoting psychedelics for everyone and being a panacea for all sort of problems. And this was a picture from what was called a love-in in San Francisco. And that's where Timothy Leary coined this phrase, turn on, tune in, drop out. So there's a lot of anxiety around this time around, from conservatives around the disintegration of society and, the challenging of authority and so on. And this was around the time of the Vietnam War, and there was a lot of concern about people not wanting to conscript and go and fight in the war. And it also coincided with a time that of change in sort of legislation around ethics and how you conducted trials that started in the US that basically said, you actually need ethical approval to do these kind of things. You can't just have a crack in your console in your rooms. And following on from that, Sandoz decided it wasn't worth their while to continue to manufacture LSD. So before, and that led to the Controlled Substance Act, which basically outlawed, and that spread to the rest of the world, which outlawed psychedelic use. But before that happened, there was actually an enormous amount of research that happened around psychedelics. One of the sort of most important ones was this Good Friday experiment, where they took, it was the first randomized controlled trial of psychedelics, where they took a number of seminary students and they divided them into sort of psychedelic or no psychedelic. And then they gathered information on their experiences. And actually, I think most of them who had the psychedelic described it as the single or close to the single most spiritual experience they had in their lives. So this ability to evoke a kind of spiritual type experience was first documented there. But the problem with the early research was that it was often single arm, so there was no comparator arm. It was often in fairly uncontrolled settings, so it wasn't in a defined research environment. And often the investigators took the psychedelic along with their subjects, and all were very evangelical or zealous about the potential benefits of psychedelics, and so lacking equipoise that generally is required for research integrity these days. Okay, so that's the history. So shifting gears, what are the drugs? So there's the serotonin agonists, which are hallucinogens, so LSD, psilocybin. I've highlighted that because I'm going to focus in on that. But other ones are DMT, so ayahuasca contains DMT plus a monoamine oxidase inhibitor, which prevents its breakdown in the gut. Mescaline, ibogaine, salvinorin, so salvia divinorum. Then there's the NMDA receptor antagonists, so they're generally what we call dissociative, so PCP ketamine, and then there's others, MDMA. So if anyone is interested in any of these other things, I'm happy to answer questions at the end, but I'm going to focus in on where most of the research is at the moment around psilocybin. That's my interest. Where do these drugs act? So they mostly act on serotonin receptors in the cortex of the brain, but they also act in subcortical regions as well. So psilocybin is naturally occurring in mushrooms, psilocybin mushrooms, and there's over 200 species. Psilocybin cubensis is the commonest one that's used in therapy, therapeutically, but it's a 5-HT2A receptor antagonist. It does act on other receptors. You can have effect down to about 3 to 5 milligrams, and that's generally the dose that people describe microdosing on. But what's considered a psychedelic dose is 25 milligrams, and that's the dose that's been used in most clinical trials. So about 50% of the dose reaches the systemic circulation, and it's actually metabolized to an active metabolite, psilocin, with those kind of half-lives there. But the duration of effect is about 4 to 8 hours. And that's probably why it's the preferred agent in psychedelic psychotherapy. So compared to LSD, where the duration of effect can be up to 8 or even 10 hours, psilocybin's a bit shorter. So what that means is you don't, in the therapeutic context, you don't have to sit with someone so long to have similar kind of peak psychedelic experiences. So what's the evidence for use in addiction? So there's been a couple of studies looking at the sort of naturalistic evidence. So what happens in the wild when people have a substance use disorder and take a psychedelic? So there's a couple of studies targeting people who self-identified as having substance issues and then had some kind of change or benefit from taking a psychedelic. So they focused on alcohol, cannabis, stimulants, and opioids. So you can see there, actually, from this study, that was sort of very self-selecting. But from this study, there was a kind of drastic decrease in the proportion of people who were kind of technically had a substance use disorder after the use of a psychedelic. And that was associated with the amount they took, the insight they expressed, the mystical experience they had, and the amount of personal meaning they attached to the experience. So this, if anything, potentially serves as a signal for further investigation. So since then, or well, around the time, there's been a few other trials. So there was this meta-analysis of LSD for alcohol, and actually that showed a pretty impressive, most of the studies there, I should say, were done in the sort of 60s, 70s, but that showed a pretty impressive improvement in sort of alcohol drinking, up to 12 months from a single dose. 12 months, you know, the active treatment controls kind of reverted back to similar levels. But as I said, I think our other therapies for treating alcohol dependence have changed a lot since the 60s and 70s. And secondly, you know, it may be that a single dose isn't sufficient, but certainly there's promise there. And again, this is a more recent study, sort of proof of concept study by Bogenschutz. Just a single arm study of people who had alcohol use disorder. And you can see here from the bottom, there's only 10 people, but you can see from the bottom here, you know, you get a very marked decrease in percentage drinking days and heavy drinking days that's much beyond any other alcohol pharmacotherapy that's currently available, or actually any psychotherapy as well. So Bogenschutz has done a phase 2 study, and we're just waiting, so a randomized control trial, and we're just waiting for that evidence to be published. So some other work looking at opioids. So this study is a pretty old one as well. It's from the 70s, but it's looking at people in rehab, actually, who they gave LSD to. And you can see there, in terms of people maintaining abstinence, obviously that's what they're very focused on in the 70s. There's a pretty substantial difference between treatment and control. And there's another body of work looking at smoking cessation. And in fact, again, single arm study, and there are other studies going on at the moment, phase 2 studies, but pretty impressive numbers of people who are still smoking free, even at 16 months. So, you know, usually in phase one studies, single arm studies, you get much bigger treatment effect size than you do phase 2, phase 3, but that's still very, very promising. So what's on the horizon? So most of the studies, and I did a search here for LSD and psilocybin. Most of the studies are looking at alcohol, but there's a number of studies looking at methamphetamine, cocaine, and some looking at opioids as well. And as you're probably aware, the MRFF, so Medical Research Features Fund, just released $15 million to fund psychedelic psychotherapies in Australia. And so in terms of addiction, sadly, there's only 2 kind of studies that got funded for this. One is alcohol, PTSD and alcohol using MDMA, and the other is for a range of other substance use disorders and DMT. So nothing on psilocybin there, sadly. So why do we think it works? Well, I put methamphetamine use disorder there in the middle, but in fact, that could probably be any drug and alcohol problem, really. And these, in drug and alcohol, you know, you kind of have a number of things going on, but they are definitely characterized by social disconnection, decrease in mental flexibility, rumination, so repetitive thinking, often negative thinking about the world and about, you know, yourself and your relationships, and a decreased ability to mentalize, so decreased ability to put yourself in someone else's shoes and understand how they're feeling. Like I said, there's already sort of a number of other early phase trials looking at show like a rapid response in a fairly limited time frame, so you get the response fairly quickly, and it's safe. And there's emerging evidence that, in fact, psychedelic-based psychotherapies are transdiagnostic. So any conditions that have this constellation of sort of associations might be amenable to psychedelic psychotherapies. So how do they work? Well, I think that this is where it gets a bit complex and the jury's still out. And there's the psychological explanations and potential sort of neuroimaging and neurobiological explanations as well. But what we know is that social disconnection and mental flexibility are the core features of addiction. And the psychedelic experience is actually one of kind of intense connectedness and increases in psychological flexibility shown by, psychological measures. So these are the theories that, psychodynamic-based theories of consciousness that basically go along the lines of the way we form beliefs is like a landscape, and the more we weight beliefs, so the more we believe in certain things, the deeper or the higher the mountains are representing those beliefs, forming a landscape of beliefs. And so what can happen is, if you get stuck on one of these mountains, which is a negative belief about yourself or the world, for example, I'm an addict, I can't do anything about it, then it's actually really hard to get off that and shift your belief about that. So there's some evidence that what psychedelics do is they flatten that landscape, so they loosen the prior weighting of those beliefs and allow you to shift those beliefs a bit more easily through psychotherapy. As I said, there's a lot of phenomenology used to describe the psychedelic experience, but this is a pretty nice one. So what happens when you have a psychedelic experience? You feel connected, you feel sort of an intuitive sense of knowledge, time and space dissolves, feel deeply positive. It's often paradoxical, which can be quite useful in terms of mental flexibility, and it can be ineffable, so very difficult to describe, but very profound. So some of the neurobiological, some of the neuroimaging, so historically, we've thought that the mesolimbic pathway, so that's your reward circuits, were at the core of causing addiction in terms of neurobiology. And that's, it may still be true, but actually more and more other brain circuits are recognized as being very important. And one of those is the default mode network. So the default mode network is pretty distributed across the brain, lots of different brain areas there. As you can see, there's a kind of frontal section and a posterior section of that. What's been shown in addictions and some mood disorders is you get an overactivity of some areas and then decreased activity in other areas that correspond with emotional dysregulation, low self-esteem, rumination, self-referential thoughts, and this decreased mentalization. And actually what happens in, it's been shown what happens after you give like a psychedelic like psilocybin is a lot of those activities are remediated, and you get increased connectivity to other brain networks as well, which is possibly positively sort of correlated with outcome. So the other thing that happens when you have psychedelics on a cellular level is that you get from experiments looking at markers of neuroplasticity, you get increased neuroplasticity. So again, this sort of corresponds with your ability to shift your beliefs and move along in your thinking. So the ability to sort of forge new connections with other important brain areas is really potentially really important in recovery. And potentially some of these are actually measurable, obviously, measurable through neuroimaging, but potentially measurable in the blood as well. And so that's another thing I'm pretty interested in. But what does this actually look like in practice? So this is a really old, as you can see, kind of 1970s picture, but it captures the kind of setup pretty well. So what we know is that the setting, so the environment that this is done in is incredibly important, because the headspace you're in when you have a psychedelic experience very much influences the experience you have. And so the way this, what we call a set and setting protocol that has been historically used in trials, what it looks like is you have a number of sessions of preparation psychotherapy where you, with a pair of therapists, the therapist dyad, you build trust and alliance, therapeutic alliance with those therapists. You develop an understanding of what kind of experience you're going to have, and you set intentions for what you want to get out of that experience. You then come into a specially dedicated therapy space, which is kind of lounge-like rather than clinical, like a clinical hospital space. And you have a curated playlist, soundtrack. You put an eye mask on, and then the therapists stay with you, but it's very non-directive. They're just really there to provide a safe space for you. And generally, people are encouraged to stay for 8 hours, so the entirety of their psychedelic experience. And then once you're done with that, you have a number of other psychedelic therapy sessions with your therapists. Mostly, so it's what's called integration. So to make sense of what's happened, and to make the most of that period of plasticity and the behavior, particularly in terms of behavior and thought change in that sort of few weeks after your psychedelic experience, to actually be able to affect some change. So what are we doing at St. Vincent's? Well, in addiction, we've got a study that's just about to get started called SIMAR, which is aiming to recruit 15 people with methamphetamine use disorder from the stimulant treatment program. So hopefully we're hoping this will get started before everyone else, and this is going to be the first in the world psychedelic psychotherapy looking at this indication. And because it is the first in the world, we're primarily just looking at safety feasibility, but we're looking at a number of other markers as well. So methamphetamine use, obviously, in cravings, psychiatric comorbidity, quality of life, and we're doing some brain imaging, resting state functional MRI before and after, as well as some biomarkers before and after, and qualitative interviews. So it's really, there's a lot of other sub-studies built into this to try and get an idea of what the mechanism is. And this is what it looks like. So we do some screening visits, we do interviews, scans, biomarkers. They have at least 3 preparatory psychotherapy sessions, dosing day, and then all the other follow-up and integration psychotherapies after that. So thanks for listening. If you want there's some other reading materials I've listed there, but also just like to acknowledge that couldn't be possible without a number of other people, and funding from NCCRED and St. Vincent's Clinic. So yeah, thanks for listening, and happy to answer any questions you have.
Thanks, John. Very interesting sphere of addiction medicine, as I think you summed it up nicely, in that people are looking for a panacea, and so we do need to temper our expectations, but by the same token, there's lots to be positive about. And I was taken aback by those results around alcohol as well. That was quite a dramatic drop in days use as well.
Yeah, absolutely. And we're not really clear about what the actual mechanism is yet. I mean, we know that it probably is targeting multiple things in substance use disorder. I think it's, obviously regulators are interested in substance use outcomes, but I think, you know, we are probably a bit more interested in quality of life and function and, you know, mental health comorbidity and things like that. And I think the interesting thing about this is it really just seems sort of like that transdiagnostic, so possibly targets all of those things, you know. But yeah, it seems very promising, but very early stages. Yeah.
While I'm waiting for some other questions, I wanted to ask, obviously in Australia, and this is not a criticism at all. Please take this question in the correct vein in which it's being given. Australia has a bit of a checkered history with some questionable trials in psychedelics. Have you run into any difficulties, you know, in terms of, you know, ethics committees, fundings, you know, just even advocacy groups or people or families who've been affected perhaps by those studies, institutions? I'm aware of one in particular that I'm thinking of that I actually grew up very close to when I lived in Melbourne. Just wanted some input on that if you got me.
Yeah, look, you're absolutely right, Chris. I think, was that the family you were referring to?
I didn't live too far away from where the family operated. Yes, well kept. I didn't live. I fortunately wasn't part of it, and I believe most of their operations moved to the Eildon area, which is out of Melbourne. But yes, I was referring to them.
Well, I think with anything with kind of that has a degree of power can be used for good or evil, I think. I think you're right. And I think that's why there's a real need to tread carefully and to do things with like as much integrity as possible, and to not be zealous about it. And so, you know, already there's a number of kind of colorful organizations and characters emerging in this sort of new renaissance of psychedelic psychotherapy that, you know, we have to be very careful about engaging with. And so, yeah, I think there's great care needed. You know, we're lucky. I mean, I'm lucky that the people I collaborate with, I would like to think are from that camp. And in fact, because we've been careful, we've not really had any issues with getting ethics approved for our studies. So we've got one and just about to have two ethics approvals for studies at St. Vincent's. And I'm also on an investigator on a microdosing study as well at Macquarie University. So to answer your question, yeah, like it's a minefield, but I think if we proceed with caution and integrity, then hopefully, you know, we should get some good research out of it. Yeah.
No, I think you've covered it nicely, and as you kind of alluded to in your presentation, beware the evangelist. Yeah. Any of these things.
Well, I think anything, and in mental health and addiction, anyone who's offering a quick cure or a magic bullet is a charlatan, until proven otherwise. Because there's not, like, I can't imagine there ever being such a thing. Maybe in the very distant future, but no, I don't think so.
No, I agree, and I think we kind of covered that nicely in this forum when talking about vaping as well last week and the pros and cons of that.
That's right.
Couple of questions have rolled in. Chris Davis said, thanks, Jonathan, very such interesting stuff. The limitations of psychedelic assisted counselling are wide, including the cost and time of two therapists. Has there been much into microdosing, which seems to be more accessible?
Yeah, no, good question. So yeah, there's not been a lot of work looking at cost effectiveness of this stuff yet because it's so early on. So there's also, I think we've got a bit of a legacy effect of some of the research as well, because in terms of this set and setting protocol, so we don't actually know whether, I mean, for those of you who aren't aware, there's a podcast out recently that looked into, it's called Cover Story, that looked into the kind of some of the ethical problems with in terms of integrity and actually even sexual assault involved with psychedelic psychotherapy, and it's pretty disturbing. So I guess we don't know whether two therapists are actually required. Certainly, people who are in a very vulnerable state when they're doing psychedelic psychotherapy, and that's historically one of the reasons why 2 therapists were required. But you might not need it for the prep and integration sessions, for example. There are other models that are being looked at. I suppose the theoretical advantage is that you get a rapid response with a very limited number of doses and a fairly limited number of psychotherapy sessions. So when you come to weigh up the cost versus the benefit, it might be the same cost or slightly more. But if the benefit is much greater than our current therapies, then there's still a possibility that it's going to be cost effective. With microdosing, there's even less evidence. In fact, there's virtually no evidence. In fact, there's no trial evidence for microdosing and addictions. My sense is that microdosing appears like slightly less promising. And one of the difficulties of microdosing in this country at the moment is that we don't know how often or what dose to give, so we think maybe you can get away with giving it twice a week, but because of the way the scheduling works at the moment, people have to attend the center to pick it up twice a week. So it's not like you can sort of dispense it and let them have it at home. So it's quite onerous as well. But I mean, I think definitely research needs to be done on both, really, to make any conclusions there. But yeah, look, I think good point, Chris. Yeah.
If I can interject for one moment, just to make sure everyone's on the same page, when Dr. Brett is talking about microdosing here, he means microdosing of psilocybin and other psychedelics. We did have a talk about microdosing buprenorphine for opioids and those sorts of things, which is an emerging sphere entirely different to that. So I don't want anybody getting confused about any of those. And if I can just clarify then, so the 2 therapists is as much a safeguard against, scandal, assault and everything else. Is that fair to say?
Yeah, so a couple of reasons. One is, I mean, and obviously, historically that hasn't always, actually, been effective for that purpose. But yeah, look, a couple of reasons. One is obviously that, and another is purely practically, it's an 8-hour dosing session. So you're going to probably need to go to the bathroom and things like that during that period. And I suppose ultimately, there's kind of some psychodynamic hangovers of all this thing, because that was where it was first developed. And the thought was you'd have a male and female therapist, representing the archetypes of mother and father, and there'd be some healing through that. But I don't particularly buy into that, to be honest. I think practical considerations are pretty important. Being able to go to the toilet and stretch your legs and things like that, it's pretty important. Yeah.
Careful, you're getting a bit evangelical there. Craig Rogers chimed in. I've said, thanks, John. He said, may have missed this, but do participants only receive the 1 dose of psilocybin, and how long is the counselling session? I think we've covered that it's a full 8-hour counselling session. And is that correct? It's just the 1 dose of the psilocybin on that day?
Yeah, so the prep sessions are usually 1 to 1.5 hours, because there's quite a lot to cover. The dosing day is 8 hours, and then the integration sessions are generally about 1 hour each. So our study is only 1 dose because we're looking at really safety feasibility. Can we do this from a public addiction outpatient? But studies of psychedelic facilitated psychotherapy for other indications do use more than 1 dose, and there is some indication that more than 1 dose can be helpful. And like I said, if you look at the mood disorder trials, the biggest, there was a study looking at from Imperial by Carhart Harris, comparing that to escitalopram, psilocybin. They used 2 doses, and there's some evidence that more can be helpful. And I suspect it's because of this phenomenon of you have a period of plasticity by which you can affect change. And if you don't sort of, it's not surprising. Like, you can't change everything in your life that's reinforcing that, you know, cycle of mood disorder or addiction or whatever it is. It's not surprising you can't change everything in 1 month or something. So, you know, we see kind of relapse rates peak around 3 months. So, you know, there's a theory that maybe you need some multiple dosing to give you more period of time to sort of, you know, affect those changes. And each psychedelic experience can be different as well. So the problem, of course, is, you know, how do you design a trial of multiple dosing with placebo control without people dropping out as soon as they know they're in the placebo arm? But that's a different conversation altogether, I think. So yeah, I mean, I guess some of the concerns around methamphetamine, you know, we've been very careful to address in terms of our eligibility criteria. So, you know, there's concerns around psychosis. We've been very careful to try and exclude people who might be at increased risk of that. But there's also concerns around dose blunting. So, you know, they both work at the serotonin receptor, methamphetamine and psilocybin. And I guess there's concerns that you're down-regulating or desensitizing your serotonin receptors when you use methamphetamine. And so we might give 25 milligrams and discover people aren't actually getting the kind of psychedelic experience we want them to, and a higher dose might be necessary. So that's probably going to be, you know, multiple dosing and dose escalation is probably going to be the next study down the track if this phase 1 goes well. Yeah.
Fantastic. Did have a follow-up just on that. You mentioned that the patients will be mostly recruited from the St. Vincent's stimulus. Is that that's an inclusion criteria? Is this a study that's available to people? And I guess our telehealth partners, if they're willing to travel to Sydney, is that something that's available to them, or do they have to be involved in the stimulant treatment program prior to commencement?
Yeah, so the initial phase of recruitment is going to be through the stimulant treatment program, and we're just going to see how things go through that. And the reason for that is just in terms of, well, one, from prior experience with other studies, I'm aware that as soon as you open it up to the general public, you often have a queue around the block. And so, you know, we prefer to keep it really simple and safe to begin with. So those patients are already known to us. Yeah, I think that's a good point, though, actually. I hadn't considered that. Maybe the next phase will be to open it up to the kind of wider network here.
I'm putting you on the spot there, which is very mean of me, but I guess I am trying to bring it home to roost that, of course, we are privileged in Sydney to have a lot of resources available to try and look at novel ways to manage these things. But you know, we've always got to keep in mind that we want to try and integrate our telehealth partners and where possible, potentially even involve their clients in these studies as well. So it's not something we're doing at the moment, which is totally understandable. And I entirely agree. You get a lot of referrals for these sorts of things the minute it goes full scale, some of which are better than others, shall we say. And so keeping it simple at this early stage when it's just a pilot and a safe, safety study, then is entirely appropriate.
Yeah.
Fabulous. All right. Well, I'm not seeing any more questions coming through. And if that's the case, we might wrap it up there. But thank you very much for a really deep and very up-to-date presentation, not just on the issues and research that's around in psychedelics, for methamphetamine use disorder, but also what's next and what we can all look forward to, because I know it's a big issue in the community. Yes, everybody's looking for the panacea. It's not there, but we are working on some good treatments that have got some good early signals. So thanks very much, Dr. Bratt.
Pleasure. No problems at all. Thanks, Chris. All right. Take care.
Thanks, everybody, and we'll see you all next week.
Thanks, John.
Thanks.